The following podcast is part of a certified educational activity titled Beyond TNF Inhibitors, Latest and Emerging Evidence on Novel Cytokine-Modulating Strategies in the Treatment of Moderate to Severe Psoriasis, featuring Dr. April Armstrong from the University of Southern California in Los Angeles. Access the entire activity and complete the post-test at peerview.com/FXM860. Downloadable slides are also available.
Hello, I'm Dr. April Armstrong, Professor of Dermatology and Associate Dean for Clinical Research at the University of Southern California. I want to welcome you to this educational activity examining new data from the AAD-VMX 2021 regarding the modulation of cytokine signaling as a therapeutic approach to moderate to severe psoriasis. First, we'll start with psoriasis burden and pathophysiology. As you may know, psoriasis affects greater than 8 million Americans, and it's one of the most common immune-mediated conditions. It's important to know that for patients with psoriasis, oftentimes the treatment options include topical, phototherapy, oral therapies, and biologic therapies. And it's important to know that when we're thinking about selecting the type of therapies that they may need, we take into account their disease severity as well as their comorbidities, such that we can select an agent that's individualized for them. There are a number of unmet needs in psoriasis, and when we think about these unmet needs, it typically falls into a number of different categories. First of all, when we think about unmet needs, we think about efficacy. So we want to oftentimes take a look at the efficacy of a particular agent, not only in terms of the short term, but also in terms of the long-term efficacy that they may have. In addition to the efficacy on the skin, oftentimes for a lot of systemic therapies, we also want to evaluate its efficacy in the joints as well. Safety and tolerability are really important concerns, not only for patients, but also for clinicians as well. And there are unmet needs, especially in the realm of oral therapies for our patients with psoriasis in terms of identifying an oral agent that may be both efficacious and also has a good tolerability profile. Now, it is very important that we define goals for our patients and also strive to work towards those goals. The NPF has body surface area of 1% or less being a goal that we want to strive towards. And as long as we communicate with our patients and make sure that they are part of this shared decision-making process, that can actually improve their adherence to our recommended therapies. And now we're going to take a look specifically at the unmet needs as it pertains to oral therapies. And specifically, we're going to dive into some of the clinical implications of new data on JAK inhibitors for moderate to severe plaque psoriasis. When we think about oral therapies, they have been one of the mainstays of therapy for patients with moderate to severe plaque psoriasis. Traditional oral therapies include acitretin, cyclosporin, and methotrexate. However, they may be associated with various adverse events, drug-to-drug interactions, and therefore may not be appropriate for some of our patients. Apremilast is a phosphodiesterase 4 inhibitor that's approved for moderate to severe plaque psoriasis as well as psoriatic arthritis. However, it does have limited efficacy in some patients. So what we see is then a lot of energy and excitement was put into the JAK-STAT signaling pathway. And this is because the JAK-STAT signaling pathway can be central in terms of the pathogenesis of psoriasis. JAK-STAT signaling is an intracellular pathway, and a number of different cytokines that are responsible for the pathogenesis of psoriasis signal through this JAK-STAT signaling pathway. And through JAK and STAT, essentially the STATs can dimerize, go to the nucleus, and their resultant action is to express additional genes that are responsible for the inflammatory cytokine or inflammatory cycle that we see in psoriasis. Now, let's take a look at this slide, which shows the different effects of targeting different JAKs. It's important to note that the downstream effects of JAK and STAT signaling, for example, depend on a number of different factors. Number one, it depends on the cytokine that it binds to the receptor. And number two, it depends on, very importantly, which JAK is paired with which JAK. When we're thinking about the JAK family, there is the TYK2, JAK1, JAK2, and JAK3. And as you can see, depending on the different types of pairing, you can have different downstream effects. Why that's important is that we want to be very targeted when we are developing a medication, for example, towards targeting intracellular signals that are specific for that particular pathway, for example, be it psoriasis or psoriatic arthritis, while preserving the other physiologically normal pathways, which may be signaled through a number of other different types of JAKs. So let's talk about TYK2 signaling. TYK2 signaling is extremely important in psoriasis and psoriatic arthritis. TYK2 mediates signaling and functional responses downstream of a number of different cytokines, and those include IL-12, IL-23, and type 1 interferon receptors. And especially in psoriasis and a number of other immune-mediated inflammatory diseases, IL-12 and IL-23 are central to their pathogenesis. A new molecule, a novel oral therapy, was developed to target TYK2, and it is called deucravacitinib. And deucravacitinib is designed to specifically inhibit TYK2 as well as its downstream signaling effects of IL-12, IL-23, and as well as type 1 interferons. Deucravacitinib is very unique. It's unique in that it binds to the regulatory domain of TYK2, which is shown here. So here is deucravacitinib coming in and binding to the regulatory domain. And this is important because by binding to the regulatory domain, it allows for that inhibition to be very specific to TYK2, and therefore it avoids the JAK 1 through 3 inhibitions, and therefore we don't see some of the side effect profiles that we typically think in terms of it being associated with a JAK 1 through 3 inhibition. Here is a table showing the in vitro data looking at the differentiated profile of TYK2 inhibition of deucravacitinib versus JAK 1 through 3 inhibitors. And again, deucravacitinib here binds to the regulatory domain and spares the active domain. As you can see, the active domain is what's conserved across these different types of JAKs. So by not binding to the active site, but binding to the regulatory site, but still have the effect of inhibiting TYK2, what we see is that deucravacitinib has a lot more specificity for TYK2 inhibition than it does for JAK 1, 2, and 3. And this is very important because by having this unique mechanism of action, that this particular inhibition is able to be specifically targeted for psoriasis and psoriatic arthritis while sparing the effects on the normal physiological pathways that are mediated through JAK 1, 2, and 3. Now I'm going to talk about some of the clinical data from 2 global phase 3 clinical trials. These are the large phase 3 pivotal trials with deucravacitinib and its effects in patients with moderate to severe plaque psoriasis. So first, what we're looking at here are PASI 75 response at week 16, which is one of the 2 co-primary endpoints. If we take a look at on the left side, what we see here is that the green line represents deucravacitinib, red line represents apremilast, and the yellow line represents placebo. And what we see here is that at week 16, deucravacitinib is superior to apremilast as well as placebo here. And the effects continue through week 24. In fact, the effect is maintained over 52 weeks. And similar results are shown in POETIC PSO2, which is an identically designed study up to week 24 as PSO1. Here we're looking at SPGA 0 or 1 or clear or almost clear response at week 16. And what we see here again is that more patients, significantly more patients, achieved clear or almost clear on deucravacitinib, 53.6% compared to 32% in the apremilast group versus 7% in the placebo group at week 16. And as you can see here, the difference is maintained through week 24, and similar results are also seen with the POETIC PSO2 study. Here are the co-primary and secondary endpoints. On the left-hand side are additional secondary endpoints compared to placebo, and on the right-hand side are secondary endpoints compared to apremilast. So what was shown here is that effectiveness was shown across these secondary endpoints that are meaningful to, I would say, both the patients as well as clinicians, that deucravacitinib achieved deep responses for skin clearance, and it also achieved great efficacy in terms of hard-to-treat areas such as scalp. In addition to that, there's a maintenance of response over time, and also achievement of quality of life for patients that are treated with deucravacitinib. Here we're looking at some of the safety data during the placebo control period, 0 to 16 weeks. As you can see here, deucravacitinib is well tolerated and the safety profile is consistent with its mechanism of action. Here is a safety profile from weeks 0 to 52. And in this particular, as you can see, longer term, week 52, what we see here is similar to what we saw in the placebo control period. And I just wanted to point out that deucravacitinib is highly well tolerated. When we look at the rates of diarrhea and nausea, for example, when we're looking at 52-week data, it's actually lower than that of placebo. So I just wanted to point out that this medication is very well tolerated, and most patients have stayed with the medication throughout the trial. Here are the laboratory parameters, which is of high interest to all of us. And the reason is because when we were looking at JAK1, 2, 3 inhibition, now different from the TYK2 inhibition, sometimes we can see perturbations in the laboratory parameters. In here, you can probably not tell which line it belongs to deucravacitinib or placebo or Premalas. What was shown was that there were no abnormalities in laboratory parameters, and when we're looking at total cholesterol, neutrophil, creatinine phosphokinase, or platelets. And as a result of its investigation in psoriasis, I want to mention that there are a number of other indications that we're looking into with regards to the applications of deucravacitinib. And those include psoriatic arthritis, ulcerative colitis, Crohn's disease, as well as lupus. Now, having talked about intracellular targeting, such as with deucravacitinib and other small molecules, let's talk about cytokine targeting. So these are extracellular cytokines that one can target with biologics. So let's take a look at cytokine targeting and the latest evidence in that. As we know from the pathophysiology of psoriasis, there are a number of different cytokines that are important for psoriasis, and those include, for example, IL-23 as well as IL-17. And here I'm going to talk about BiMichizumab, which is an IL-17 inhibitor, cytokine inhibitor. And specifically, we're first going to talk about a study comparing BiMichizumab versus Secukinumab called the BRADIANT study. BiMichizumab is a biologic that is in late phase development, and BiMichizumab works in the following way. BiMichizumab, which is shown schematically in this green monoclonal antibody here, can bind to 3 different dimers. It can bind to IL-17AA homodimer, AF heterodimer, or FF homodimer. As you can see here, BiMichizumab can bind to both IL-17A as well as IL-17F. Both of these cytokines are important in the psoriasis pathogenesis, and F is actually a more abundant cytokine compared to A, IL-17A. As you can see here, by binding directly to IL-17A and F, BiMichizumab prevents these cytokines from binding to its respective receptor complex. So how did BiMichizumab do against Secukinumab in this head-to-head study? What we see here on the left-hand side is PASI 100 response at week 16. As you can see here, BiMichizumab was superior to Secukinumab at week 16, and on the over here, this part of the bar graph is at week 48. And what we see here is that also it's superior to Secukinumab at week 48. Over here, we see 3 bar lines looking at the same data, but over the time course period. So we're looking at PASI 100 from week 0 to week 48. And the 2 BiMichizumab arms are one of them here, the darker purple one represent BiMichizumab every 4 weeks throughout this period, and the pink represent BiMichizumab every 4 weeks for the first 16 weeks, and then transitioning to every 8 weeks thereafter. And the blue represents Secukinumab. So as you can see here, all three medications, all three of these doses and medications worked quite well. BiMichizumab at both of these different regimens were superior to Secukinumab through week 48. So from this data, what was concluded was that BiMichizumab achieved superior levels of complete skin clearance as defined by PASI 100 versus Secukinumab at week 16 and at week 48 in both the 320 milligram every 8 weeks a group and maintenance of treatment of 300 milligrams every 4 weeks as well. And by week 4, there was seen a faster response with BiMichizumab compared to Secukinumab. And overall, the safety profile of BiMichizumab was similar to that of Secukinumab. And now we're going to look at BiMichizumab in patients with plaque psoriasis who are receiving continuous BiMichizumab or switched from Adalimumab. On the left-hand side, we see the PASI 90 response, and on the right-hand side, we see the PASI 100 response. So these are week 56 responses in week 24 PASI 90 responders. So these are people who have who deemed to have achieved PASI 90 by week 24, and we see how they did over time. So what was shown in this study was that the vast majority of patients who did not achieve a PASI 90 response at week 24 from the Adalimumab group, when they switched to BiMichizumab, they showed rapid and sustained improvement after the switch. And patients who achieved PASI 90 after week 24 of Adalimumab or BiMichizumab treatment was able to maintain or improve their response further with further BiMichizumab treatment. And now let's take a look at BiMichizumab for the treatment of scalp psoriasis, and this is a post hoc analysis. And what is shown is that at week 4, after one dose of BiMichizumab, more than 50% of the patients with moderate to severe scalp psoriasis achieve complete scalp clearance. So this is important because scalp is oftentimes a very difficult area to treat for many of our patients, and we oftentimes clinically have seen patients who were cleared elsewhere on the body but still had stubborn scalp lesions. Importantly, this also showed that higher proportion of patients achieved complete clearance of scalp psoriasis through week 24 with BiMichizumab compared to Adalimumab. And also the median time to scalp clearance was lower, so it took shorter amount of time to achieve response with BiMichizumab. Now, one question you may have is, how does BiMichizumab work across different patient subgroups? Does the response vary by age, baseline weight, or disease duration? And what was found was that BiMichizumab had high levels of skin clearance that was durable in patients with plaque psoriasis, regardless of the dosing regimen, whether we're talking about every 4 weeks or every 8 weeks, and regardless of the different patient subgroups that we looked at, which included age, different patients in different age groups, baseline weight, or disease duration. Now, how about the speed of clinical response? We know that's important because our patients oftentimes want something that's very fast, and having something that's fast acting can also really engender therapeutic confidence between the clinician and the patient. And so what was seen was that the inhibition of IL-17A and IL-17F with BiMichizumab resulted in more rapid clearance of psoriasis versus Ixekizumab, Adalimumab, or placebo. And the median time to achieve that rapid clearance was also much shorter in the BiMichizumab group. Now we're going to switch gear and talk about another IL-17 inhibitor, Secukinumab. Secukinumab is the first IL-17 inhibitor that was approved in treating moderate to severe plaque psoriasis. And here we're going to look at a study that looked at different doses of Secukinumab and how they did in patients who weighed 90 kilograms or above. Now, before I start, just as a reminder, as you know, that Secukinumab is typically dosed per FDA labeling every 4 weeks during the maintenance phase. And here we're looking at patients who weigh greater than 90 kilograms and asked the question, if they didn't achieve optimal response, if we dose intensify them, if we give them every 2-week dosing, will they do better? And here is the study design, as we can see here. So here we see the results of what happens when we take our patients who weigh 90 kilograms and more, who had been on Secukinumab but didn't respond as well to the 4-week dosing. What happens if we dose intensify them to every 2 weeks? So let's first take a look at the PASI 90 response. The lighter blue represent those patients who had been dose escalated to every 2-week dosing. So as you can see, 76% of them achieved PASI 90 at week 52, compared to if they were maintained on every 4-week dosing. That is 52% of them achieved PASI 90 response, and this difference is significant. And a similar difference was also seen with IGA 0 or 1 response, representing clear or almost clear. So I would say from this data, it's convincing that what we see here is that in patients who weigh 90 kilograms or more, so for our heavier patients, if every 4-week dosing is not working for them, dose escalating them to every 2-week dosing can increase the efficacy and can increase their response and improve not only their psoriasis disease severity as measured by PASI 90 and IGA 0 or 1, and probably their quality of life as well. So that is a very important pearl that we can take away from this. And again, in patients who are heavier, if you don't see any response with every 4-week dosing, 300 milligrams every 4-week dosing, if that's not working, consider switching them to every 2-week dosing. Okay, and now let's take a look at Secukinumab in comparison to Adalimumab. And this is a study comparing patients who are either randomized to Secukinumab or Adalimumab, and looking at both their skin as well as their joint response. And why this study is important is that oftentimes there's a debate with regards to, especially for the joints, which one is better? Is it IL-17 better or a TNF better? And I think we now have more and more data showing that for the joints, the medications can work quite comparably. So for example, as we see here for the ACR 20, 50, 70 response, the blue bar represent Secukinumab and the orange represent Adalimumab. As you can see, the two medications track very closely with regards to its response, while the response was numerically higher for Secukinumab, it was not statistically significant, as you can see here. Now, what if we combine ACR 20? What if we combine joint response as well as the skin response? What do we see? So here, what we see is that the number of patients who achieve both good joint as well as good skin response, there were more proportion of patients on Secukinumab who achieved that compared to patients on Adalimumab. The p-value here was 0.06, so it didn't quite achieve statistical significance, but as we can see here, there were a numerical difference here with this combined outcome. Now, when we look at the skin alone, it's probably no surprise that Secukinumab here in this trial that look at both skin and joint, if we just look at the skin alone, that Secukinumab was superior to Adalimumab when we're looking at PASI 90 response or PASI 100 response. Now, what about Secukinumab in terms of managing axial manifestations? Here, we're looking at first part here, we're looking at ASAS 20, which is a measurement of axial manifestations. As you can see, Secukinumab is able to maintain axial control of the axial manifestations through week 52. And then down here, we're seeing the clearance of nail psoriasis in patients treated with Secukinumab. And the main takeaway from that is that long-term improvement. As you can see, the improvement keeps on going. The line keeps on going, keeps increasing here in terms of the response rates in patients with nail disease. So likely the longer that we treat patients with Secukinumab, the better that the nail is going to respond. And here is a study from the AAD-VMX looking at Ixekizumab and Gazylkimab in terms of improving skin clearance and itch and quality of life. What was shown was that both medications did very well in terms of improving skin clearance, decreasing itch, and improving patients' quality of life. What was also shown was that more patients treated with Ixekizumab versus Gazylkimab reached greater than 12 consecutive weeks of PASI 90 or PASI 100 response. And now here's a poster that our group presented at the AAD-VMX looking at the comparative efficacy of treatments for the various options that we have. And this is important because in clinical practice, we're oftentimes not choosing between medication A versus placebo. We're oftentimes choosing between a number of very good options. And here is a look at the efficacy synthesis using network meta-analysis. As you can see here, we have a lot of different therapeutic options, and we have many biologic agents that are in the realm of a very good efficacy. And we also have earlier biologics that we used. While they were very, very useful when they came out, in relative comparison to the newer biologics, their efficacy is considered to be lower now, and just given the different options that we have these days. And here is another poster that's presented by Dr. Blauvald's group looking at cumulative clinical benefit of biologic treatment for psoriasis over a year. So instead of looking at one point in time, for example, at week 16 or at 1 year, they're looking at the cumulative benefit of biologic treatment over 1 year period of time. And I think the main thing about these type of studies is that they're actually pretty consistent when we're looking at the various network meta-analysis. So as you can see here, Ixekizumab, Adalimumab, Secukinumab, Risankizumab, Gazylkimab all had very good cumulative benefit over 1 year period of time, and were better performing than some of the other biologics that are shown here, some of the earlier biologics that we have. So in conclusion, one is that we learned from this talk, hopefully targeting the JAK-STAT pathway is an important therapeutic MOA. And importantly, we now have a novel oral TYK2 inhibitor in development, in late stage development for the treatment of psoriasis, where we see good efficacy and good tolerability profile. And in terms of a new data and news from the biologic realm, we have another molecule that's in development that targets IL-17A and F, BiMichizumab, and this new mechanism action has shown to have brought forth extremely robust efficacies in our against psoriasis. And then finally, we are having continued evaluation and efficacy of the safety of the existing systemic therapies that have been approved and in use for patients with plaque psoriasis. And it's important to look at these in terms not only of comparative efficacy, but also safety, such that we can really take into account all this data and think about patients' disease severity, think about their comorbidities, think about their preference, and come up with an individualized and optimized therapy for our patients. And with that, I want to thank you very much for your attention and for spending the last 30 minutes or so with me. And that ends our discussion today. I hope that you found this discussion helpful and informative to your practice. I also encourage you to access the supplemental materials. Thank you very much for participating.
This activity is accredited by Medical Learning Institute, Incorporated. This activity is developed with our educational partner, PVI, Peer Review Institute for Medical Education. Thank you for listening. Download materials and complete the post-test for instant credit at peerreview.com/FXM860. This activity is supported by educational grants from Novartis Pharmaceuticals Corporation and UCB Incorporated.